Purpose of heart valves. So we have 4 heart valves, 2 AV valves, 2 semilunar valves. So what do they do? What are the functions of the valve? Why do they open and close? So what are they making sure happens? Or what are they preventing from happening? They're preventing backflow. So they ensure only one directional flow of blood. One set of valves open when the atria contract, another set open when the ventricles contract, right? So they open and shut. So as long as their integrity is intact, they're not leaking, therefore they will ensure blood only flows in one direction. So therefore, what's a consequence if valves do not open completely or do not shut close? Yes, go ahead. Congestion. And what is always the consequence when there's congestion? What will form? Blood clots. Okay. So any difference from AFib, aflutter? No. Same exact effect. Okay, so patient is at risk for what happens to cardiac output? And what will happen to the likelihood of clots? Increases. Understand? Okay, so same here. So therefore, what will be part of the treatment? Aside from surgical repair, so anticoagulants. And what else? What does the patient develop if there's congestion? Besides the clotting problems. You've done congestion like in the first module. So there will be pulmonary what? Could be, but there will be. Is there heart failure? Yes. So what's always part of the treatment of patients with valve disorders? Heart failure treatment. Because does this patient develop heart failure? Yes, whenever you have a valve disorder, valve disease, you have heart failure, correct? You agree? Or do you disagree? Okay, this will lead to, if you go back to heart failure chapter, this is one of the causes of heart failure, wasn't it? Yes. There are only 2 possible problems. Patient may have both. So it's either a valve does not completely open or a valve does not completely close. Patients may have both. Patients may have multiple heart valve problems. Either way, what does the patient have? Heart failure. What will we treat the patient with? What type of medications? Medications for what? Heart failure. What else? Anticoagulants. Very good. As far as the questions and as far as the signs and symptoms, let's keep it simple. It really depends on what valve is affected. So let's start with the mitral valve. Where's the mitral valve? Left or right side? Left. So what type of heart failure will result? Right-sided. Where is the mitral valve? What type of heart failure will result? Left-sided. Just think about it. So if this is my mitral valve is right here. If it doesn't open or if it doesn't close completely, where is the congestion? On the left or the right? It's on the left. So therefore, what type of heart failure will I have? Tricuspid or pulmonic valve is either stenosed or regurgitant. What type of heart failure will I have? Right side. Make sense? That's it. Let's go to management. So there are many valve disorders. Again, prolapse, that means what does it mean when it prolapses? Does it go up or down? Down. Down. Can it shut completely? No, it's prolapse. So therefore, what will happen to So they're either prolapses, that means it doesn't completely close. If you read here, I'm not going into that much detail, but not all of these, especially MVP, are symptomatic. Meaning, for example, I have a friend who's now, he just turned 50. He's still asymptomatic. He's had MVP since birth. He's very athletic, plays tennis, basketball, no symptoms whatsoever. Okay. So it really depends. Definitely aortic stenosis patients, do you think they're symptomatic? Aortic. Definitely. Okay, definitely. There's no such thing as an asymptomatic aortic stenosis patients. Regurgitation, that means the mitral valve is leaking. So again, another example of doesn't completely close. Then we have stenosis, doesn't completely open. Regurgitation, a leaky aortic valve. So this one would be a little better compared to aortic stenosis. Stenosis, definitely those patients, depending on the severity, are very symptomatic. So this one would be one of the worst types of valve disorders the patient will have. Now let's go to management. Again, signs and symptoms. What did I say are the signs and symptoms? Heart failure. Just depends on which side. Where's the location of that valve will determine whether or not the patient will have left side or right side heart failure. What type of arrhythmias do you think will develop? Because you said there's congestion, correct? So when there is congestion, what will happen to the AFib usually develops in these patients? Okay. Let's go to management. Now, if it's repairable, they will repair it. If not, then they'll have to replace it, correct? Okay, so let's discuss the management, because you're the ones taking care of this patient before and after surgery. Now, if the patient has repair or replacement, that means is the valve still its original shape, structure? No more. So therefore, are they at risk for an infection? Yes. Yes, they are at risk for endocarditis. We'll discuss endocarditis on the next topic. So therefore, with patients who underwent either valvuloplasty, which is repair, or valve replacement, the patient is at high risk for endocarditis. The main portal of entry for endocarditis is the mouth, meaning any dental work, any dental cleaning, extraction, root canal, whatever dental work you have, or if you have any wounds in your mouth, that is the portal of entry, #1 portal of entry for endocarditis. There are, of course, others. However, because of this fact, what should the patient receive before any dental work or dental surgery? Antibiotics, okay, before we start any invasive oral procedure. Are we clear? All right. Now let's go to replacement. So if the patient undergoes valve replacement, same thing, we do prophylactic antibiotics before any dental or oral procedures. However, there are two types of valves that can be used here to replace the patient's original valves. So it's either biologic. When we say biologic, that's another person's valve or another animal's valve. So it's usually a pig valve or a cow's valve. They pick those animals because they have the same heart size, yeah, same heart size and similar anatomy. So we use those to replace. If it's biologic, because it's living tissue, is it likely to clot? It's living tissue. Is it likely to clot? It's living tissue. Not likely, because it's biologic. I mean, what will the body see if it's, it's biologic? I mean, it's a living tissue. So therefore, is it likely to attract blood clots? No. However, If it's made of steel or titanium, is it likely to clot? Yes. So both patients, either biologic or synthetic or mechanical valves, will need prophylactic antibiotics. However, which one will require lifelong anticoagulation? The mechanical valve only. Are we clear? What's the reason again? Okay. Biologic valves usually do not attract blood clots. So here's the comparison. So either mechanical valves like this. Okay. If it's mechanical, you'll literally hear, because it's metal, titanium or steel, so it will cause a click. So every time these things open and close, you'll hear a click. Right? So instead of a lub-dub, you'll hear lub-click. Okay, this is a mechanical valve. And here's the tissue. So this is biologic, coming again from a human cadaver or pig or cow. They haven't done horses or sheep. It's usually just pigs and cows. So here's the mechanical valve. So this one will require what again? Anticoagulants. Both will require prophylactic antibiotics. Okay, regardless if it's biologic or mechanical, you need, because you're at risk for endocarditis. So therefore, you need prophylactic antibiotics. But who needs anticoagulation? Okay, so here, significant complications associated with mechanical valves are what? Thromboembolism, thromboemboli. Are we clear? So therefore, they require long-term anticoagulants. Like how long? Forever. As long as you have this mechanical valve, you need anticoagulants. Okay. That's about it. Any questions on valves? Okay, let's go to infections now. First infection is, let's start with rheumatic endocarditis. This type of endocarditis, regardless of the endocarditis, this is infection of the endocardium, which is the innermost lining of your heart. This is where the blood actually goes in. Okay, so you have 4 chambers of the heart, right? So blood enters the atrium and the ventricles, correct? So this is where this is the actual lining where blood touches. So this is the endocardium. So how do you think this infection got there? How did this endocardium get infected? First and most common is rheumatic fever. How do you get rheumatic fever? From strep throat. So if you have an undiagnosed or untreated strep throat, can you develop endocarditis? Yes, there are other causative organisms, of course. Now, the manifestations, we'll get to the signs and symptoms, but usually these type of infections, endocarditis, always damages the heart valves. Okay, so therefore, can they damage the heart valve? Yes. Okay, so we already completed the discussion on valve damage and the signs and symptoms and management, so I won't repeat that. So what other causes of valve disorders? Endocarditis. Okay, so this is another cause of a valve disorder. Okay, then most common causative organism is strep throat. So is strep throat something you disregard? You treat with vodka? No, you need to treat this. Very simple test. You just need to swab, right? You get a diagnosis and then finish the antibiotics. Okay, so you prevent endocarditis this way. Because is it going to be a permanent damage to your valve if you don't treat it? Yes. That is if you survive endocarditis. We'll get to the manifestations and management shortly and complications. So rheumatic fever, again, coming from strep throat, is totally 100% preventable. Okay, so you can, as long as you treat strep throat, you won't get rheumatic fever, you won't get rheumatic endocarditis. Clear? As simple as that. So here are your symptoms of your strep throat. Okay. The more common type of endocarditis is infective endocarditis. Okay, so we have rheumatic caused by what again? Strep infection. Infective is caused by other infections. I mentioned earlier the most common portal of entry is the mouth. Okay, so that could be an open sore in your mouth, you know, any wound, open wound in your. We'll look at all the possible portals of entry. IV drug users are also at risk for this. Obviously, dirty needles. Okay, they get the infection in their blood, and then the infection enters the endocardium. Okay. So here's the IV drug users. Other risk factors include patients who have central lines, PICC lines, central lines, doesn't matter, tunneled, non-tunneled, hemodialysis catheters. Because are these invasive lines? Very invasive, okay? So therefore, they will cause endocarditis. So the infection enters the blood, and then the infected blood enters, of course, the heart. Now, why do you think the organism ends up in the heart valve? Why the heart valve? Why do they damage the heart valve? What do bacteria need to live? Oxygen. What else? What else do you need to live? You're not a bacterium, but you're a living organism also. So oxygen, you need oxygen, you and me. What else do you need? Which is sugar, right? Yeah, glucose. So where do you find the best oxygen, the best glucose? Yeah, but where exactly? Blood from where? Which is, where would you find the best glucose, the best oxygen? Where can you find that? Which side of the heart? The right or the left? You say right side. Is there oxygen on the right side? The left. No. That blood is deoxygenated. I wouldn't want to live there. There's no oxygen. So it's the left. The left side of the heart has the best oxygen. That's the first, yes, chamber, right? That coming right from the lungs. Fresh oxygen. And which valve happens to be on the left side? The mitral valve. So which valve is commonly affected by endocarditis? The mitral valve. Okay. So if you're IV drug user, make sure you use a sterile needle. Okay. Don't reuse. Okay. Don't share needles. Okay. That's no good. You get endocarditis, then you're not saying you die. You probably survive, but then you'll have heart failure. Because does this damage the valve? Yeah, we already agreed. Heart valve disorders cause heart failure. Then you get repair or replacement. Then you need prophylactic antibiotics before any surgical or oral dental procedures. Okay. All right, let's go now to the risk factors. So let's complete it. We already discussed this previously, earlier on the valve disorders. So patients' valves, heart valves were either repaired or replaced, then they are at risk for endocarditis. Implanted devices, pacemaker, ICDs, okay, because these are foreign objects, right? Here, if you had a history, you had endocarditis before, does that mean you're immune? I already got it. I already had it last week. No, you're even at higher risk for another one. Because how did you get it in the first place? That means, did you have risk factors? Yes. Did you get rid of those risk factors? No. So hemodialysis, that's the central line, correct? So here, body piercings. So I don't know how many body piercings you guys have. Make sure you go to a reputable provider, okay? Not some cheap ass body piercings, okay, that don't have proper hygienic practices, okay? Because here you could get endocarditis. Manifestations. So we mentioned the heart murmur earlier, correct? Is this an infection?
No.
This is not an infection?
What, the heart murmur?
No, the endocarditis.
Yeah. Oh, yeah.
It's an infection. So what does, what does a patient who has an infection feel? How do you feel when you have an infection? Yeah, you feel lousy, right? Yeah, tired, body aches. Yeah, I don't want to eat. I don't want to go to school. Okay. So you feel like that. And then damage to the heart valve now results in a murmur. So you either have a new or a change in a murmur, meaning if you had a murmur before you got the infection, now you have a change in that murmur. Okay, so either you get a new murmur. What causes the murmur, by the way? Why do you hear a murmur? That means the valves are not what? They're not closing. Remember, if they shut tight and close, you will hear lub-dub, right? That's what produces the heart sound. It's the closure of the valves. They don't close because you have a valve disorder, and therefore you hear a murmur. So if you hear there's any leaky valve, it will result in a murmur. Will this disappear after treating the endocarditis? No. Not unless you repair or replace it. Okay, the valve, the murmur will stay. Then you'll have some petechia. What are petechia again? Which are evidence of what? Clots or bleeding. These are microscopic areas of bleeding, right? Okay. This is caused by microembolization. Now, the embolization here is coming from the vegetation. It's described here in this paragraph right here. So the bacteria, when they settle in the heart valves, they make houses there. The houses are called vegetations. Okay, what are vegetations? Yeah, like like what's vegetations in your backyard? Like bushes, weeds, right? So those are vegetation. So bacteria do the same thing. So would they like to live in the left side of the heart? Yes. Yes. Okay, I want to have kids here. I want to have my grandkids, my great grandkids, all my friends. I want to house them here. Okay, so it's a nice place. I get the most oxygen here, best sugar. I'll stay here. Okay, I don't think I want to go anywhere else. I like it here. Okay, so they make houses on the which valve? The mitral valve. Now, I'm not saying, don't get me wrong, it can infect other heart valves as well. But what do you think will be the most frequently affected one? The mitral valve, because of its location, right? Prime, you remember real estate? Location, 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 right? So this is the best location. So these vegetations here, are they made of cement, very best civil engineering material? No, these are made by a bacteria. So therefore, are they really constructed very sturdy? Can they break off? Yes. Yes, they can crumble and break off. Now, what happens to these tiny vegetation that are now floating in the bloodstream? They are emboli. Okay, so they are floating debris. Can they clog tiny capillaries? Yes. And then it can cause bleeding. So that's what's responsible for these petechia right here. Okay, so they clog small arteries, usually in the hands and the feet. We call them Janeway's lesions. And then they can also damage the capillaries in the eye. Okay, so these are all manifestations, and they're almost exclusively found only in endocarditis patients. Here, Osler's nodes, these are found in your fingers, and then we have Janeway's lesions. Okay, these are macules found again on your palms, fingers, and then the bottom of your feet. Okay, and then this one is in your eye. Okay, this is now in your retina. So the doctor will examine your eyes. They'll see rot spots. Okay, so these three, Osler's node, Janeway lesions, and rot spots are exclusively found in endocarditis. These emboli, are these blood clots? Did I mention that they were blood clots? No, they were the vegetations, remember? They're not blood clots, so therefore, can you treat these with anticoagulants?
No.
No, it will not work because these are not blood clots in the first place. To begin with, these are not blood clots. So can you stop the Janeway lesions, the rot spots? No. You're just screwed. If you have them, that's it. Okay? Because you can't, I mean, how do you dissolve them? They're not blood clots. Okay? We don't have a product that will dissolve vegetative emboli. Okay? There's no such thing. So you still want endocarditis?
No.
Okay. And then what's the complication again? Because you have valve damage? Patient also develops heart failure. So there can be a little fight here because let's talk about your patient population. So you work in a unit, correct? Specific unit, either med-surg, telemetry, ICU. When we assign patients, it should be appropriate. Like you should put the patient in the right unit, right? Is this a medical or is this a cardiac problem? It depends, right? It depends. If there's evidence of heart failure, is this a cardiac patient?
Yes.
In which case they go to which unit? Telemetry, cardiac telemetry. If there's no evidence of heart failure, where should they go? They should stay in med-surg. Okay. So this is kind of because it adds to your census, right? So sometimes, especially in HHC, they don't have very good standard, black and white stuff. So I see when I go to clinical with you guys, I see endocarditis patients in telemetry. Why? I mean, why is this patient here? Patient's walking around, telemetry's fine, there's normal sinus rhythm. Why is this patient here? How do we confirm the diagnosis? Is there a dysrhythmia here? No, so no EKG. So what? The blood, it will grow what? Whatever causative organism is causing the infection. Okay, so very good answer. So we need a blood culture to confirm the diagnosis. What else? How do we know whether or not there's damage to the heart valves? How can we see the heart valves? The echo, okay? So echo. So either transthoracic or transesophageal. Okay. Transesophageal is more expensive because it's invasive. Transthoracic, which is over the skin, is cheaper. So here, definitive diagnosis will be made with what again? Blood culture. Okay. So after you treat this, so let's say we treat the patient, does that mean what will happen? How do we know it worked? How do we know the infection was successfully treated? We draw blood cultures again and see where did it disappear. Okay, it's clear now. Very good. We did it. So at least 2 sets. Okay, 2 sets of blood cultures. And then, of course, we'll look at the other parameters of an infection. Because remember, this is an infection. Okay, so we look at white blood count. What else do we monitor? ESR and CRP. These are inflammatory markers, okay, of infection. Doesn't matter. This is not exclusive to endocarditis. Anyone with a blood infection should be monitored for ESR and CRP. These all arise together with your WBC. Okay. So how do you know the antibiotic is working? Because the intervention here is 4 to 6 weeks of IV antibiotics. So do we check the blood culture at the end only and then during those 4 weeks, nothing? What do we do in between? What do we check in between? Check what? the WBC, ESR, and CRP. So if these levels are going down, is our antibiotic therapy working?
Yes.
Yes, because it'll be too late if we wait for the blood culture at the end. Okay, we're wasting time, correct? Okay, we don't want to wait till the end. We have to monitor every week. Yeah, no, either we change. Okay, so maybe we made a mistake on the blood culture. Okay, let's draw another blood culture. What actually is there? Why didn't this antibiotic work? Okay. Could be, I mean, that's outside our realm, okay? We are in the nursing. So this is all part of our monitoring. So here's the echo, either TEE here, TEE, or TTE, transthoracic. Prevention. So what are these patients at risk for again? So therefore, can this be prevented? Yeah, what do we do? Prophylactic, right? Antibiotic before any dental or oral work. Okay, so here. So any dental or oral wounds, okay, are the most common portal of entry. So that's why we have antibiotic prophylaxis before any of those procedures. And of course, do good dental hygiene. Don't share toothbrushes, right? So use a dedicated toothbrush for your toilet and one for your mouth. Don't interchange. You guys do that to your husbands?
Yes.
Okay, so treatment, here's the treatment. You give them antibiotics for, it's not really 2, it's 4 to 6 weeks. But your textbook says 2, then fine. But anywhere between 2 and 6 weeks. So since this is long-term antibiotic therapy, what will be our route? And what will be our IV access? Peripheral or central line? What did you remember earlier was one of the portals of entry? Central line. So therefore, can this mode of treatment predispose the patient to another infection? Yes. So therefore, this emphasizes what? Strict aseptic technique. Okay, so you use the central line bundle. Okay, make sure you clean it properly, change dressings. We discussed this already, right? Yeah. How often do we change dressings? Central lines? If it's a clear dressing, once a week, 5 to 10 days. If it's gauze and clear dressing, what will it be? Every 2 days, every 48 hours. So the surgery here is, of course, if the patient develops heart damage, valve damage, then it'll be either repaired or replaced. And we already discussed that. Any questions on endocarditis? That's it. Okay, let's finish today with pericarditis. I'll skip myo. Myocarditis is the infection of the muscle layer of the heart, but it basically means heart failure. Because if the muscle of the heart, the endocardium, the myocardium is infected, what will happen to the contractility? Decrease, right? So therefore, the patient develops failure. Easy as that. But of course, it's in an infection. Do they receive infections? Antibiotics, sorry. Yes. And endocarditis also, do they still receive treatment for heart failure on top of the antibiotics?
Yes.
Okay, last one for today, pericarditis. This is now the infection of the outer lining, okay, the sac around the heart. So we already talked about the endo, and then briefly the myo, and then now this is the pericardium that is infected or inflamed. So this is the sac, the membranous sac enveloping the heart. So this is the one that's infected now. Now let's see the causes first. How do you get it? There are 4 causes here. Number 1, after an invasive procedure. Now, what type of surgical procedures involves cutting through the pericardium?
What if you make a cigar?
No, a stent?
Heart.
Stent is done in the cath lab. You don't slice the heart. You go through the artery. Pacemaker, the wires are inserted through, it was described earlier, subclavian, jugular. No. What procedure will cut through the heart muscle? You're cutting through the pericardium. Open heart surgery. Right, so you're either changing the, well, not all heart valves, because you know what? TAVR is a breakthrough procedure. They can now replace heart valves in the cath lab. Can you believe that? They can do that now. Anyway, if the hospital doesn't have TAVR, then they'll have to do it the traditional way. They'll cut your sternum open and then cut through the heart, blah, blah, blah. Okay? So any procedure that will involve cutting through the pericardium, of course, has the risk of pericarditis. What else? After an MI. Now, if it's 10 days to 2 months after a heart attack, we call that Dressler syndrome. So that's the second cause. Why does it occur? Well, when we say MI, was there any death of myocardial tissue? Infarction. Yes, parts of the heart muscles died. So if there's anything dead there and the pericardium is stuck to that dead area, will it cause inflammation? Dressler syndrome. A third is if the patient had a heart attack today and they get the pericarditis within 24 to 48 hours after the heart attack, that's pericarditis, straight up pericarditis, okay? If it occurs 10 days to 2 months, what do you call it? Dressler syndrome, okay? Fourth cause is lupus. Have you heard of lupus?
Yes.
Okay, so that's the last and fourth cause. Lupus is a connective tissue disorder, meaning it will cause inflammation of all your connective tissues. What are the connective tissues in the body? Hair, skin, mucous membrane, blood vessels, blood, joints, synovium, peritoneum, pericardium, pleura, fascia. These are all connective tissues, okay? Organs, all organs have connective tissues. So can it cause pericarditis?
Yes.
Yes, among others. Signs and symptoms. The patient will develop pleuritic chest pain. It's painful because does the heart ever stop beating? Now, if you have a inflamed sac and then sac around the heart. So imagine scrotum, okay? So if your testicles are beating against this inflamed scrotum, which is what the heart is doing here. Heart keeps beating, right? 60 to 100 times every minute. And the pericardium, the sac around it, is already inflamed. So what will happen? Imagine you have a blister in your heel. You keep walking, you keep dancing, you keep partying. It's painful, isn't it?
Yeah.
Will there be a fluid around it also? Will it cause a blister? Yes, this is exactly what's going to happen here. So a patient experiences pain with every heartbeat, constantly, ow, ow, ow. It's worse when they are laying down. So when they're laying down, that means the heart is against the spine, correct? And then that will make the pain worse. The pain will improve if they sit up straight and lean forward. So when they do this, the pain improves. Okay, so this would be the most comfortable position. Sitting upright, leaning forward improves the pain. Of course, can they take NSAIDs? It's painful. And it's inflamed. Yes, NSAIDs would be good here. We get to the interventions later. So these are the manifestations. Okay, so patient's number 1 complaint is the pain, the pleuritic chest pain. It hurts. And when you examine the patient, listen to the heart sounds, you'll see creaky or scratchy friction rub. So we call this a pericardial friction rub. And of course, it's an infection. So there will be increased WBC, etc. ESR, CRP is also elevated. Now, the danger here, remember that blister I talked about? Okay, if the water or the fluid accumulation inside this pericardium gets more than 50 ml or more, we call it cardiac tamponade. This is life-threatening. This is an emergency. Patients dead within 5 minutes if you do not treat cardiac tamponade. So I already did the causes. So here's the lupus and we did the heart attack, okay? And the infectious, of course. So here's the pericardial friction rub, and then the scans and echo would see pericardial effusion or the tamponade. Now, if it is a tamponade, is this life-threatening? Yes. The emergency procedure here, once you will get to the signs and symptoms of cardiac tamponade, your only action is to what? Call the doctor. Call rapid response. Call the doctor, and the doctor will have to perform pericardiocentesis. This is guided by ultrasound because we need to know how far the doctor needs to insert a needle. The needle here is about 8 inches long, and we're gonna insert it through the sternum, into the pericardium, and then drain the fluid, okay? Unless you have other ideas. No, that's how we deal with it. So this is, the doctor will perform pericardiocentesis, but he needs to know how far the needle must be inserted, okay? Because otherwise he'll puncture the heart. Okay, so we need ultrasound to do that. If the tamponade is not, the build-up is slow, then they can do a CAT scan guidance or MRI, okay, to drain the fluid. But in an emergency, only ultrasound. That's the best we could do. Okay, so here's interventions now. So what can we do about this patient? They're in pain. So besides the positioning, okay, what position again is best?
Straight and forward or lean forward.
Okay, like this, right? Sit up straight, lean forward. You can give NSAIDs. Steroids can be used if it's caused by lupus. Are we clear? What if it's caused by an infectious process? Can you use steroids? What will happen to the infection if you give a patient who has an infection steroids? It will get worse. Colchicine, this is usually used for gout. This can be added to the NSAIDs, seems to improve with pain management. Okay, I already discussed what pericardiocentesis is. So here's your nursing management. So pain management is your priority. Position the patient, provide support. So here's the position again. Forward leaning, sitting position. Let's look at the signs and symptoms of cardiac tamponade. Now, it's not here, it's in chapter 25. Let's see if there's, it's called Beck's triad. Right here. So these are the, among others, but these three are called the Beck's triad. This is proof of cardiac tamponade. They are hypotension, muffled heart sounds, jugular vein distension. What are they again? Okay, so let's explain. Why does the patient have these? So imagine this is your heart. This is the sac. This is the pericardium. Okay. Now, if I put water, I wish this was plastic. If I put water inside this pericardium, what will happen to venous return? Remember, the heart shares the mediastinum with two lungs. I have two lungs here. The heart occupies the mediastinum. Is there any way it can expand? No, it's limited to that area because there's lungs here. So if this is my pericardium, my heart, but I added so much water inside this pericardium. This pericardium is supposed to only hold maybe 5, 10 ml. That's it. Now I have 50, 60, 100, 150 ml in there. So what happens to the... So now I have so much water in the pericardium, right? So can the heart filling be normal? No, because now I'm drowning. I have water all over here. There's a right lung there. There's a left lung. There's no space. I'm like this. So what happens to venous return? Low. What happens to cardiac output? What happens to blood pressure? Explains the hypotension? Okay. Let's go to the muffled heart sounds. Why does the heart sounds sound like they're wearing a mask? Because there's fluid, okay? I cannot hear the heart sounds clearly because there's too much fluid around. So when I put my stethoscope, I'm hearing the heart sounds over water. Okay, there's water here around the heart, so it sounds muffled or distant. It's like far away. And then finally, why does my jugular vein distend?
Fluid.
Is there fluid overload here? What's causing my jugular veins to distend? Again, this is my... It's compressing the water, the fluid here, blood or whatever fluid is in the pericardium, is compressing the heart. So therefore, venous drainage from the head, is it normal? What happens to the... There's pressure in my head. Yeah. So the venous drainage from the head decreases. So therefore, it will distend my neck veins. Any question on the Beck triad? Okay. So that is your pericarditis patient. This is where you put the stethoscope. So if I give you a hotspot question, like where would you put the stethoscope? Can you answer? A hotspot question. So here it is. So this is how you answer. Where will you place the stethoscope? Where exactly? So where is the left sternal edge in the fourth intercostal space? Where is the left sternal edge? Where is your sternum?
The middle.
Right here. So therefore, 1, 2, 3, 4, right here. Okay, that's where I put my stethoscope. I'll change it up a little bit because I already gave you the answer. So pain management, NSAIDs, right? And what else can be added? Steroids or colchicine. Okay. Unless what again? Who should not get corticosteroids if the cause of the pericarditis is what? No, they will help with lupus. It will help lupus.
The person that has an infection.
It's an infectious process. And watch for the complication, okay? Cardiac tamponade, this is dangerous. What are those again? The 3, the Beck triad. ABD, hypertension, muffled heart sound. Other books may say distant heart sounds. Okay, so distant or muffled, same thing. Just in case, I doubt if they'll do this, but pulsus paradoxus, let me explain what this is. So pulsus paradoxus is a there's a difference in the blood pressure. The patient's blood pressure rises during exhalation. It drops during inhalation. Why? If there is cardiac tamponade. Kurt, why does the blood pressure drop when the patient inhales, but then when they exhale, the blood pressure increases? Okay, you remember cardiac tamponade. Can you picture cardiac tamponade?
Yeah.
Okay, so I have fluid around my heart, right? Okay, so when I inhale, both lungs squeeze the heart. So what will happen to my blood pressure, cardiac output? It's gonna drop, okay, because my heart is squeezed. But what happens when I exhale? So therefore, my cardiac output improves. So that's what pulsus paradoxus is. Okay, so higher blood pressure during exhalation, lower during inhalation. That's it.